Hello, good morning everyone. Today's our seminar is on heart failure, preserved ejection fraction, current management and future perspective, which will be presented by Dr. Sibasis Sahoo sir, who is a professor in cardiology and having 15 years of experience. Thank you. Looking forward for your kind presence.
Thanks Dr. Himal for your introduction. Today we will discuss a very interesting topic and simultaneously also very important topic of management of heart failure with preserved ejection fraction. What is its current status and future perspectives? It's actually, we know, it's two sides of the same coin. At time we know the management of heart failure with reduced ejection fraction. Yes, with the same coin we should also know the other side of the coin, that is heart failure with preserved ejection fraction. So what is its current status and future perspectives? Now coming to the definition. For the first time, European Society of Heart Failure Guidelines last year 21 and this year recently released SCCHA Heart Failure Guideline. Both the guidelines have agreed to this definition, that is heart failure according to the left ventricular ejection fraction. If ejection fraction is less than 40%, they have grouped into heart failure with reduced ejection fraction. If ejection fraction is 41 to 49%, they have grouped those subgroups into heart failure with mildly reduced ejection fraction, and if the ejection fraction is more than or equal to 50%, they have grouped into that heart failure with preserved ejection fraction. Previously, in the last guidelines, European Society of Heart Failure Guidelines, they have grouped that mid-range, that is 41 to 49% ejection fraction into mid-range ejection fraction. But for the first time, they have now kept this group as heart failure with mildly reduced ejection fraction. What is the epidemiology of heart failure with preserved ejection fraction? What is the global prevalence? The global prevalence is across all the continents, it's about 1 to 2%. 60 million heart failure patients worldwide now suffering from heart failure, and 50% of those patients are with heart failure with preserved ejection fraction. So what is the epidemiological trend of HFpEF in our country? According to Indus studies done by AIIMS New Delhi, it's first of its kind community based study. Basically they have conducted in rural population, where the prevalence of heart failure is found to 1.2 per 1000 rural population, out of which 67% patients were heart failure with preserved ejection fraction, and all patients of HFpEF had uncontrolled hypertension, and 2.5 times prevalent, particularly females were prevalent 2.5 times as compared to males. According to Trivandrum Heart Failure Registry, where they have conducted primarily 90% population were urban, where the prevalence of HFpEF was found to be 25% as opposed to the Indus study. And again similarly, female were more prevalent as compared to males, and comorbidities were hypertension and type 2 diabetes mellitus. There are various also community based studies in our country, but these two studies were very important. These are the conclusion from various Indian studies what I have taken. HFpEF constitutes more than 50% of patients with heart failure in community setting. As compared to Western population, Indian patients with HFpEF are relatively younger, about a decade. That might be due to increased prevalence and younger age of onset of comorbidities like diabetes and hypertension in our country. More commonly, they are found in females, and most prevalent risk factor in our country was hypertension. Overall mortality higher in our country as compared to West. So the question arises, is the diagnosis of HFpEF being missed in India? Answer is yes. Why? Because most of the clinicians can't make diagnosis of HFpEF confidently. That's because when the patient comes with dyspnea presented to our emergency department, what we do? We do routine investigations. At times we do not find any etiological reason. Then we do screening echo, LVEF ejection fraction found to be normal. Then we establish those cases as non-cardiac cause of dyspnea. And we similarly prescribe a cocktail of diuretics, bronchodilators, antibiotics, antihypertensives. And routine biomarkers test, usually we do not do. Comprehensive echo evaluation for diastolic dysfunction also we do not do. So we at times miss diagnosis of HFpEF in our country. So what is the natural history of HFpEF? All cause mortality was lower than that for heart failure with reduced ejection fraction. Annual mortality rate in epidemiological study is found to be around 10%. However, in randomized control studies, they are around 5%. Heart failure with preserved ejection fraction with comorbidities, the mortality rises more than twofold. And what the mode of death? Mode of death, most likely it is cardiovascular in about 50 to 70%, and in non-cardiovascular causes, they are around 30 to 40% mode of death. So, what is the pathophysiology? Does HFpEF follow nosographic trap hypothesis? Answer is yes. So, what is nosographic trap hypothesis? That means from conceptual point of view, this disease spectrum appears too exciting but too weak to group so many intrinsically different diseases under the same umbrella. That is what is nosographic trap hypothesis. HFpEF includes patients with multiple different phenotypes, multiple different pathophysiology, and having widespread geographic heterogeneity. These are the basically schematic representation of pathophysiological difference between HFpEF and HFpEF. That means reduced ejection fraction and preserved ejection fraction. In reduced ejection fraction, basically there occurs increased sympathetic system activity and increased renin-angiotensin aldosterone system activation, and side by side also natriuretic peptide system activation. But in HFpEF, what happens? There occurs increased systemic inflammation, particularly generalized endothelialitis, that subsequently releases inflammatory markers like interleukins, demon recursive factor, and CRP. All those contribute to damage to the heart muscles and vasculature. This is the basic difference in the pathophysiology between HFpEF and HFpEF. So, what happens with HFpEF? There occurs LV relaxation abnormalities. What happens? There is a decrease in the LA to LV diastolic gradient. That gives rise to impediment of early diastolic filling of left ventricle. That subsequently gives rise to increased LV diastolic pressure and increased LA pressure. And secondly, there occurs LV increased diastolic stiffness, that contributes to decreased LV compliance and diastolic distensibility. These are the basically the pictures showing LV diastolic pressure volume relationship. What I told in the previous slide, that is early diastolic filling impediment, that is LV relaxation abnormality. The first picture, that is picture A, there is abnormal relaxation. What happens in early part of diastole? There is abnormal, due to abnormal relaxation of the LV, there occurs increased LV end diastolic pressure. However, increased LV pressure in the early diastole. However, in late part of diastole, LV diastolic pressure may or may not be normal. But in the early part, yes, definitely it is, the filling pressure it is raised. And coming to picture B, where there is a chamber stiffness increases, subsequently there is increased LV end diastolic pressure from mid to towards the late part of the diastole. And in figure C, there is pericard constraint, that means when there is constrictive pericarditis, this simultaneous similar increase of diastolic pressure throughout diastole from early part to late part of diastole. And in the figure D, there is when there is chamber dilatation, particularly in reduced ejection fraction group, there occurs in the late part there is increased LV diastolic pressure. Understanding the mechanism in 2022 of this heart failure preserved ejection fraction syndrome, basically what happens in all the systems are involved in the HFpEF syndrome. All the systems contribute to the pathophysiology of HFpEF in 2022. That means in particularly cardiac part, there occurs direct and indirect myocardial lipotoxicity, and recently various literatures they are actually publishing data regarding particularly epicardial fat tissue that contributes to the HFpEF by releasing inflammatory cytokines and causing subsequent damage to the heart muscles. And pulmonary, particularly chest wall restriction, reduced vital capacity, and obstructive sleep apnea and pulmonary hypertension. And liver, yes, is non-alcoholic fatty liver disease, is now no more benign. They also contribute to release of cytokines, inflammatory cytokines also contribute to the HFpEF. And renal also, direct toxic effects of perinephric fat and very important, that is visceral adiposity, contribute to HFF by releasing inflammatory cytokines and neurohormones and increase BNP clearance. All of them produce metabolic stress, cardiac remodeling, ventricular vascular stiffening. They contribute to loss of cardiac vascular and skeletal muscle reserve, and at last develop heart failure with preserved ejection fraction. This is the another pathophysiology actually published in European Journal of Heart Failure 2020. Impaired systemic venous capacitance, the neglected mechanism in patients with HFF. Yes, particularly in inflammatory metabolic heart failure group, as compared to hypertrophic or amyloid cardiomyopathy group, if you look at the systemic venous capacitance, is found to be impaired. That's why those subgroups typically show favorable response to diuretics as compared to hypertrophic or amyloid cardiomyopathy group. If you prescribe diuretics in hypertrophic amyloid cardiomyopathy, usually they are intolerant, they will develop hypotension. However, this inflammatory metabolic heart failure with preserved ejection fraction group, because of impaired systemic venous capacitance, they will show favorable response to diuretics. So how you diagnose this syndrome? According to 2021 European Society of Heart Failure guidelines, they have divided like heart failure reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction. Criteria 1, 2, 3, symptoms plus minus signs according to either Framingham criteria or Boston criteria, with ejection fraction less than 40%. And in the that mildly reduced ejection fraction group, similar symptoms of plus minus signs, ejection fraction 40 to 49%, with requirement two things, that is elevated level of natriuretic peptides, and second is at least one additional criterion, that is the patient should have relevant structural heart disease and diastolic dysfunction. Similarly, also preserved ejection fraction group. So ESC 2021 says signs and symptoms of heart failure, they are often non-specific. They do not discriminate well between heart failure and other clinical conditions. These are the objective evidence of cardiac structural, functional and serological abnormalities consistent with presence of LV diastolic dysfunction. So what are the parameters? These are parameters: LV mass index, like it should be more in females more than 95 gram per square meter surface, and males it should be more than 115, and relative wall thickness it should be more than 0.42. Relative wall thickness means that is the 2 into left ventricular posterior wall thickness divided by LV end diastolic diameter, should be more than 0.42, and LA volume index should be more than 34 ml for square meter surface area, particularly if the patient is in sinus rhythm. If the patient is in atrial fibrillation, should be more than 40 milliliter per square meter surface area. And from tissue Doppler, mitral valve E by E prime arteries should be more than 9, and biomarkers NT-proBNP and BNP, these are the biomarkers. If sinus rhythm, these are my finding, and if the patient AF, also a different level. And PS systolic pressure should be more than 35 mm mercury, and tricuspid regurgitation velocity at rest should be more than 2.8 meter per second. These are the objective evidence of left ventricular diastolic dysfunction or raised filling pressure. So what are the various diagnostic scoring of this syndrome? These are H2F, PEF score. The H2 means heavy, hypertensive, F atrial fibrillation, P for pulmonary hypertension, elderly and filling pressure. All of them are accorded with several different points. Total point is 0 to 9, so that we can calculate what is the probability of this syndrome in your patient. Now, European Society of Guidelines, they have released this algorithm in 2019, that is Heart Failure Association HFA PEFF algorithm, or P for pre-test assessment, E for echocardiographic and natriuretic peptide score. Particularly when the standard echo has failed, you are desired for comprehensive and more elaborative echo. That is what is diagnostic workup, but we have to do comprehensive echo, and side by side we have to do natriuretic peptide scoring. And FF, that is F1, is when there is diagnostic uncertainty, that is you have to do, that is a diastolic stress test or exercise stress echo or invasive hemodynamic measurement, that is functional testing. And second F is for etiological workup for final etiology by doing cardiac MR or something or CT or PET like this. First we have to go for step 2, that is advanced or comprehensive echo plus natriuretic peptide scoring. This is the step 2, that is advanced echocardiography or natriuretic peptide heart failure scoring. They have divided into two criteria, major or minor criteria. Major criteria they have been given 2 points, minor criteria given 1 point. In major criteria they have included functional category, morphological category, biomarkers. If it's sinus rhythm and atrial, they are different level. And functional category, that is mitral valve, septal or lateral E prime, these are the value, or average E by E prime more than 15, or TR velocity more than 2.8 meter per second, or PS systolic pressure more than 35 meter. They are grouped into major criteria. Minor criteria, average mitral valve E by E prime should be 9 to 14, or global longitudinal strength should be less than 16%. These are minor criteria. Accordingly, they have also given in a morphological criteria like left atrial volume index, left ventricular mass index, and relative wall thickness. These are the criteria, various criteria. If by adding all the points, the point scoring system increases more than 5 points, yes, the diagnosis is established. If the point system shows at 2 to 4 points, then there is diagnostic uncertainty. In that case, you should proceed to step 3, that is functional testing by doing diastolic stress test or invasive hemodynamic measurements. This is step 3. What you will do? First, you will do stress echo. If average E by E prime exceeds more than 15 or TR velocity more than 3.4 meter per second, then criteria is fulfilled. If not, then you perform hemodynamic measurement test like at rest. If LVEDP more than 16 milliliter mercury or PCWP more than 15, then yes, diagnosis established. If the LV index does not exceed 16, then subject the patient for hemodynamic stress test. If PCWP found to be more than 25 milliliter mercury with stress by supine bicycle exercise, then heart failure with preserved ejection fraction is established. Okay, this is step 3. Coming to step 4, that is final etiological workup. We subject the patient for echometry and otherwise cardiac MR, PET or CT scan or endocardial biopsy for establishing the final etiology for HFpEF. What are the echocardiac assessment of LV function in HFpEF? First we will discuss diastolic properties, then systolic properties. As we know, there are diastolic properties. There occurs grades of diastolic dysfunction from grade 0 to grade 3. Grade 0 means normal, grade 1 means impaired relaxation, where there is increased or normal LVEDP, but mean LV pressure remains normal, mitral valve E less than A, mitral valve E prime reduced. And grade 2 diastolic dysfunction, what is called as pseudonormalization, where there occurs increased LV and diastolic pressure with mean LV pressure, mitral valve E by A 1 to 1.5, and mitral valve E dash also substantially reduced. And grade 3 diastolic dysfunction, where there occurs restrictive feeling, occurs there is increased LV and diastolic pressure as compared to grade 2 diastolic function, and mitral valve E by A is more than 1.5, and mitral valve E by E prime by tissue Doppler is also found to be raised. Valsalva maneuver, if you do if you subject the patient for this Valsalva maneuver, you can distinguish reversible from irreversible grade 3 diastolic dysfunction by such criteria. These are the echo picture showing various grades of diastolic dysfunction. The upper panel shows mitral valve pulse Doppler and the lower panel shows mitral valve tissue Doppler. What happens if so? You see there is a increasing basically E by A ratio as diastolic dysfunction progresses, and also deceleration time gradually decreases. And tissue Doppler, if you see, particularly E dash but E prime is absolutely reduced in all the diastolic dysfunction groups. That's how you can distinguish pseudonormal diastolic dysfunction from normal LV function. In pseudonormal diastolic dysfunction, if you do tissue Doppler, absolutely there will be reduced in E prime. However, E prime will be more as compared to E prime in normal LV. So what are the various non-invasive estimation of LV diastolic filling pressure? As you know, I just described grade 3 diastolic dysfunction and as a peak RV systolic pressure more than 35 meter mercury and raised LA volume index more than 35 ml per square meter surface area. And in tissue Doppler, mitral valve E by E prime, yes, it's most frequently used for measuring LV diastolic filling pressure and is easily interpretable and is validated in labs. If it is less than or equal to 8, that means normal LV filling pressure or mean LA pressure. If it is between 9 to 15, that is gray zone. If it is more than 15, yes, so definitely mean LA pressure is found to be raised. If median annulus is used, more than 15 is the criteria. If lateral annulus is used for measuring E prime, then the mitral valve E by E prime should be more than 12 for considering raised mean LA pressure. However, in few studies, they have taken average of medial and lateral annular velocities for measuring LV filling pressure. See, there are the situations where the use of mitral valve E by E prime is unreliable. There are 4 conditions. There are tachycardia where there is fusion of E and A velocities. Second is when there is unreliable measurement of E velocity like significant MR, AR. Third is when there is unreliable measurement of E prime velocity like already patient has undergone mitral valve repair replacement, when there is severe mitral annular calcification, significant mitral stenosis, presence of LBBB, and fourth group is constrictive pericarditis when there occurs the typical annulus paradoxus. The situation where the measurement of mitral valve E by E prime is unreliable. So what are the alternative echo approaches for estimation of this LV endoscopic pressure? First is pulmonary venous Doppler, these are the findings. Second is mitral inflow propagation velocity and isovolumic relaxation time. These two equations are taken by linear regression analysis. You can measure LV endoscopic pressure non-invasively by putting those parameters. Then last is strain and strain rate from speckle tracking echo. That is global diastolic strain rate during isovolumic relaxation, particularly that ratio E by that is strain rate in isovolumic relaxation time, that also predicts LV filling pressure even in patient with normal ejection fraction. And this is the most recent, that is left atrial longitudinal strain during systole. Actually we are conducting this study on, there is an ongoing project in our institute now. If the LA longitudinal strain is less than 30% during systole, that means LV filling pressure is raised. So there are the diastolic properties we have discussed. Now coming to systolic properties. So what happens to the systolic properties in patients with HFpEF? In HFpEF, that means reduced ejection fraction group, we know there is decrease in ventricular contract, that is LV end systolic elastance is reduced in reduced ejection fraction group. However, it is normal or increased in HFpEF group. Arterial elastance is increased in reduced ejection fraction group, that's because of increased sympathetic system activation. Also, elastance was found to be raised in HFpEF group. So what happens to the ventricular vascular coupling? That means ventricular vascular coupling is impaired in HFrEF group, but it is preserved in heart failure with preserved ejection fraction group, and that is basically the concept of the mechanism of action of vasodilators in these two subgroups. So what is the clinical implication of this ventricular vascular coupling? There occurs conversion of energy of LV contraction into stroke work is suboptimal in reduced ejection fraction group, but it is optimal in HFpEF group. So the role of arterial vasodilators is found to be beneficial in reduced ejection fraction group. That's because vasodilators will decrease the arterial elastance and subsequently it will give rise to increased LV stroke work. However, there is no role of arterial vasodilators in HFpEF group because there is preserved ventricular vascular coupling. That's why even this theoretical concept also translated into various studies where all the vasodilators are found to be not beneficial in patients with HFpEF group. They are found to be beneficial in reduced ejection fraction group. That's the basic mechanism. So coming to the management, how will manage this group? There are three components management I will discuss. First is reduction and prevention of pulmonary and peripheral vascular congestion. Second component, aggressive treatment of comorbid diseases. And third component is optimization of cardiac functional status. Coming to the first component, that is reduction and prevention of pulmonary and peripheral vascular congestion. First is non-pharmacological therapy. Fluid and salt restriction should be less than 2 gram per day sodium restriction. Avoidance or reversal of obesity, exercise training, and daily monitoring of weight, and patient education and close medical follow-up. This is the remote monitoring based tailored management, particularly putting a wireless pulmonary artery sensor into pulmonary artery in patients with heart failure with reduced ejection fraction. This concept is studied in Champion trial, particularly taking populations in USA, in United States of America. They have inserted this implantable hemodynamic monitor, that is CardioMEMS heart sensor in pulmonary artery. They have measured pulmonary artery diastolic pressure. They have found heart failure hospitalization is significantly reduced by 33% in 1 year, and by about 3 years, at the end of 3 years, they have found 60% significant reduction in heart failure hospitalization, and that is particularly in American population. And subsequently, in last year, in 2020, MEMS heart failure, this is the study conducted in European population. This study has also found in this annualized heart failure hospitalization rate significantly reduced by 60% if you put this implanted hemodynamic monitor in pulmonary artery. Now, what are the pharmacological therapies? These are the current status now. Beta blockers, S inhibitors or ARBs, digitalis, aldosterone antagonists, that's mineral corticoid receptor antagonist. In the right side, there are the studies. Most of the studies are found to be not beneficial in the management of heart failure with preserved ejection fraction group, except for this last one, that is implantable hemodynamic monitor CardioMEMS study, that is what we have discussed just previously, Champion study and MEMS heart failure. Both that means beta blockers, ARB, endocrine antagonist, all even sacubitril valsartan, actually all of this study has not found to be that beneficial in this subgroup as compared to the reduced ejection fraction group. There are the prior outcome trials, that is CHARM preserve trial taking candesartan, PEV CHF trial taking perindopril, iPreserve taking ivacetone. These are vasodilator studies. They are all found to be not beneficial in HFF group. However, in TopCat group, though there is no benefit if you take the all population, but if you take the particularly American population in these studies, basically TopCat studies conducted across whole world. If you exclude Russian population, if you take only American population in this study, yes, they have found to be, spironolactone is found to be beneficial in treatment of heart failure with preserved ejection fraction group. Stepwise review of the latest data on this subgroup, on this heart failure preserved ejection fraction group. And now coming to the Paragon heart failure study, basically this study has taken sacubitril valsartan, that is ARNI, as compared to valsartan. At the end of 4 years, there is definitely non-significant reduction of 13% in cardiovascular death and total heart failure hospitalization. Though there is statistically insignificant reduction, yes, a p-value is nearing to 0.05. It's not that close, but yes, but there is a non-significant reduction, about 13% in cardiovascular death and total heart failure hospitalization. However, in subsequent subgroup analysis, particularly in female subgroup and LV ejection fraction subgroup from 45 to 57%, there is a significant about 22% reduction in heart failure, hospitalization and cardiovascular death. So the concept arises, can you treat this mid-range of ejection fraction, that is 45, 42, that 60% group? Yes, there is definitely, if you look at the studies like CHARM studies, TopCat studies, and in the right side that is the meta-analysis of Paradigm heart failure and Paragon heart failure, yes, there is definitely a trend in the reduction of cardiovascular death and heart failure hospitalization in this particularly mid-range ejection fraction group. So what are the recent studies and future prospects? All these studies, particularly soluble guanylate cyclase stimulators like vericiguat, praliciguat, and then the PD5 inhibitor sildenafil, isolated mononitrate study, all are found to be not beneficial in this HFF group. Now coming to that is EMPA-HEART study, particularly taking a population of type 2 diabetes with coronary disease, and they have studied the effect of empagliflozin, that is SGLT2 inhibitor, on left ventricular mass. They have found there is significant reduction in LV mass index following empagliflozin treatment. Then subsequently last year 2020, DAPA LVEF trial is published in European Heart Journal. This study also shows patients with diabetes, there is a significant reduction of LV mass and LV mass index following treatment with dapagliflozin. So what is the mechanism action? Proposed mechanism action is dapagliflozin causes favorable hemodynamic effect, like the reduction in preload, reduction in blood pressure, and metabolic factors like increased glucose excretion, increased hyperinsulinemia, and insulin resistance also reduced, and obesity, inflammation like decreased body weight, decreased inflammation, all of them contribute to reduction in LV mass and LV hypertrophy. Now comes the phase 3 mortality morbidity trials with SGLT2 inhibitors in this HFF group. There are two studies with HFF group, patients with and without diabetes mellitus, like Emperor Preserved and Deliver heart failure study. Emperor Preserved studying the empagliflozin, Deliver HF studying dapagliflozin. Emperor Preserved is published 6 months back in NEJM, and Deliver heart failure studies now about to come by end of this year result. And now coming to Emperor Preserved study, which is published in NEJM in October. They have studied the empagliflozin heart failure with preserving fraction with and without diabetes mellitus. The study has shown significant about 20% reduction in the heart failure hospitalization and cardiovascular death, and this benefit is mainly driven by decrease in the heart failure hospitalization about 27%. And if you look at the subgroup analysis of this study, particularly 40 to 50% of ejection fraction group, they have derived maximum benefit of about 30% reduction in the hospitalization group, heart failure hospitalization, and in 50 to 60% group, about 20% significant reduction in the heart failure hospitalization. And this is the study published last year, the Figaro DKD diabetic kidney disease, Figaro DKD, that is cardiovascular events with finerenone in kidney disease type 2 diabetes. Finerenone is basically a novel third generation non-steroidal mineral corticoid receptor antagonist. First and second, that is what we know, spironolactone and eplerenone. The third generation is finerenone. The Figaro DKD has also shown there is reduction in cardiovascular death and heart failure hospitalization, about significant, that is about 13% reduction, and again this is mainly driven by reduction in heart failure hospitalization by 30%. Now this is the study Fine Arts heart failure trial. This is an study, ongoing study, enrolling patients from 2020. What is the role of finerenone in this patient, whether it will reduce morbidity mortality in all comer population. This is ongoing study. Now coming to the reduce left atrial pressure heart failure trial 2, say actually study, novel study, basically is interventional study. They have implanted Corvia device, that is an intra-atrial shunt device across the intra-atrial septum. The aim is to reduce LA pressure, mean LA pressure. LA pressure will be decompressed to LA pressure will be decompressed to RA. That the main concept. This is a Corvia device, basically having 8 millimeter central aperture, by which LA pressure is reduced. The result recently published only 1 month back in Lancet. That study has shown the non-significant reduction in primary composite endpoints of cardiovascular death and heart failure hospitalization. However, subgroup analysis has shown patients with high pulmonary artery pressure on exercise more than 70 and left atrial volume index more than 30 milliliter per square meter surface area, they have derived significant benefits, published just last month in Lancet. So what guideline says? Before publication of Emperor Preserve, this is the European Heart Failure Guidelines 2021. In heart failure with mildly reduced ejection fraction, all the groups like ACE inhibitor, ARB, beta blocker, mineral receptor antagonist, sacubitril valsartan, they have all been grouped into class 2B. But in SECHF heart failure guidelines recently published this year, they have given SGLT2 inhibitors to class 2A recommendation depending on the result of Emperor Preserve trial. However, similar ACE inhibitor, ARB, ARNI and MRA and beta blockers all have been grouped in 2B as similar to ESC heart failure guidelines 21. Now regarding preserved ejection fraction group, ESC heart failure guideline 2021 similar. All these treatment group have been kept in class 2B recommendation. However, in SECHF heart failure guideline 2022, they have again grouped SGLT2 inhibitors in class 2A and all others in class 2B. Now coming to component 2, that is aggressive management of comorbid diseases, like you have to control hypertension strictly, diabetes mellitus, treatment and prevention of myocardial ischemia, also management of obesity by diets or drugs or bariatric surgery, strict control of CKD, correction of anemia and correction of obstructive sleep apnea. And coming to component 3, like optimization of cardiac functional status also, you have to prevent excessive tachycardia or bradycardia, to match heart rate according to metabolic need, to maintain or restore sinus rhythm, to control ventricular rate during atrial tachyarrhythmias. The face of FF is definitely changing every day. The use of probability scores can aid in the process of making a diagnosis. Those patients with mildly reduced ejection fraction may respond to treatment like patients with more severely reduced ejection fraction. Other therapies such as new forms of mineralocorticoid receptor antagonists like phenylephrine may be on the horizon for treatment of this group. Devices, particularly Corbia device like intra-arterial septal device, may be an option for the treatment of HFpEF in the near future. Phenotyping patients and administering treatment specific for the underlying phenotype could be a more effective approach for heart failure with preserved ejection fraction group. Thank you.